It's the afternoon now, and a fantastic session. Welcome to this session, which is a satellite symposium that has been sponsored by Medtronic. My name is Roxana Mehran from Icahn School of Medicine at Mount Sinai. I'm here joined by, our idea is to think about how we could transform the practice of TAVI. If we could go to the next slide. To remind you all of our fantastic panelists who are here. Professor Vijay Kunadian, myself, Professor Didier Tchétché, Professor Julia Grapsa from the UK, Didier Tchétché from France, and then, of course, I always mess it up. Joanna, Professor Joanna, but I always mess it up. Would you say it again?
Wykrzykowska.
Wykrzykowska from the Netherlands. We're really, really thrilled. Today, we will look at insights into the landmark trial, the SMART study. I was lucky enough to be one of the co-PIs with Professor Tchétché here. And we're going to talk about TAVI and the small annulus and a very important transforming our findings to the patient population of women. And of course, very importantly, addressing the diversity and the disparities of not diagnosing perhaps aortic stenosis, especially in women. And then the latest data on TAVI and what's coming up next, especially with regard to the durability. So I'll turn this over to my co-chair, Professor Kunadian, who's going to introduce our first speaker.
Thank you very much, Professor Mehran. Welcome, everybody. It's my pleasure to invite Professor Didier Tchétché, who is the lead investigator and my good friend in the SMART trial. He's going to provide the results of the trial, a landmark head-to-head randomized controlled TAVI.
So good afternoon, everyone. So waiting for the slides. So it's my great honor to share with you the main outcomes, the main results of the SMART trial, focusing on patients with a small aortic annulus undergoing TAVI with two different TAVI platforms, the most popular devices. So what we know is that there may be an hemodynamic superiority of the self-expanding supraannular platform in comparison with the intraannular balloon expandable valve based on different registries. We also know that potentially these hemodynamic differences may translate into poorer outcomes or different outcomes in the future. And this is particularly relevant for the small aortic annulus population, for which we may find up to 40% of women who are underdiagnosed, undertreated, underrepresented in most of the randomized trials. And so the idea of SMART was to assess the performance and the safety of the two most popular TAVI devices, the self-expanding supraannular Evolut cohort platform and the balloon expandable intraannular SAPIEN-free cohort platform in patients with a small aortic annulus and a symptomatic AS. So this was really a global randomized trial, 83 sites all across the world, and we were lucky enough to have a quite decent amount of patients enrolled in Europe, and I have to congratulate all the investigators for that. So as I said, this was a prospective randomized controlled trial post-market that tried to enroll more all-comer population, including all the risk spectrum and even bicuspid patients. Patients had to be symptomatic, a small aortic annulus as defined per CT scan with a cutoff of less or equal than 430 millimeters square, and there was a one-to-one randomization per site and stratification per sex. And at the end of the day, after the exclusion, the patient that crossed over, we had 715 patients in the as-treated population. So there were two co-primary endpoints, very important and very meaningful ones. The first was a clinical co-primary endpoint that was powered for non-inferiority and assessed at 12 months. And this is the usual composite of all-cause mortality, disabling stroke, and rehospitalization for heart failure. And with the 8% margin, 85% power was achieved with 700 patients. The second co-primary endpoint was a valve performance endpoint, and it was powered for superiority. And it was a composite of hemodynamic valve, structural valve dysfunction, defined as a gradient, a mean gradient greater or equal to 20. Non-structural valve dysfunction with the severe patient prosthesis mismatch or more than moderate total aortic regurgitation. And then we had the endocarditis, the thrombosis, and any aortic valve intervention, and this was powered for superiority. If both endpoints, primary endpoints, were met, we had the right to hierarchically test a certain pre-specified number of secondary endpoints, all powered for superiority, and they are listed here. And these are the echo parameters that we assess on a daily basis, and focusing particularly on the women population and powered for superiority. So baseline characteristics of the study population. So mean age was 80. And very important, and this is really contemporary concern, an issue that we debate now more and more, 86 to 87% of female, close to 90% of the patients were female, and this is relevant as we deal with a small aortic annulus population, and the mean STS score was 3%. In terms of procedural data, and this is quite important, particularly for those who are interventional, we are TAVI operators. The patients randomized to a self-expanding platform, the self-expanding Evolute Pro, Pro Plus, Evolute FX, received in the vast majority of the cases either a 26 or a 29 millimeter device, but that is only the label size of the device. It's meant for anchoring. The functioning portion of the device is about 22 to 24. For the balloon expandable valve, the vast majority of the patients, 90% of the patients, had received a 23 millimeter device. And you can see on the right part of the screen that in terms of procedural timing, contrast load, these were minor differences. And to me, what is quite reassuring is the quality of the procedure. You can see that in the self-expanding arm, only 1.1% of valve embolization. So the technique is mature, and this tells for the excellence of the outcomes that we're going to see afterwards. So the co-primary endpoints, the clinical endpoint, was exactly similar between the self-expanding platform and the balloon expandable valve. So we can state that in small aortic annulus patient, women with an aortic stenosis, there is equipoise in terms of clinical outcomes between the self-expanding supraannular platform and the balloon expandable valve. And you can see it on the right part of the slide. Wherever you dissect any component of that co-primary endpoint, it's exactly the same. The second co-primary endpoint, the valve performance, and this was quite striking when we saw for the first time the results. 32.2 difference in terms of bioprosthetic valve dysfunction in favor of the self-expanding supraannular platform in this population of small aortic annulus. And you can appreciate once again on the right part of the screen, the slide, the magnitude of these differences when you take individually the various components of this endpoint. So both primary endpoints were met, right to hierarchically test secondary endpoints powered for superiority, and you can see that all these secondary endpoints, whether it be the mean gradient, the EOA, with a mean gradient difference of 8 millimeters of mercury, EOA 0.5 centimeters square, larger EOAs with the self-expanding supraannular platform. Everything was assessed by echo. Hemodynamic structural valve dysfunction, BVD in women or moderate or severe PPM. Everything was in favor of self-expanding platform with p-values very extremely significant, less than 0.001. So other parameters were assessed because we know that this is more an integrative approach. So whether it will be the DVI, severe patient prosthesis mismatch, And more interesting finding, the total AR was more pronounced with the balloon expandable valve, and this is something that we saw for the first time, but it was mainly the mild aortic regurgitation that seemed to be more frequent, with a p-value significant for the balloon expandable valve. So quality of life assessment, a similar quality of life, but if you go more into the details and add granularity to this assessment, more the magnitude of improvement was more pronounced, seemed to be more pronounced with the self-expanding valve at 12 months, with more patients with a substantial improvement after TAVI with a self-expanding valve. Women, I guess it's becoming more and more a focus, because we all now better understand the differences that may exist between male and female. And if we focus even more in depth into the female population, everything is slightly more a bigger difference, a bigger advantage of the self-expanding valve in terms of bioprosthetic valve dysfunction, patient prosthesis mismatch, and once again the quality of life. So to conclude and to remain on time, so what we can say is that the SMART trial met both the primary and all 5 pre-specified secondary endpoints, and we can say that compared with the balloon expandable valve, the self-expanding supraannular SCV self-expanding valve demonstrated first non-inferiority in terms of clinical endpoints at 1 year. Second, superior valve performance at 1 year, 32.2% lower BVD, 8 millimeters of mercury of difference, greater EOA by 0.5 centimeters square, 2.2 greater DVI, and 7% lower incidence of severe PPM. And on top of the improvements in terms of quality of life and aortic regurgitation. So based on these large hemodynamic difference, we may expect that in the future this is going to translate into different clinical outcomes. So thank you very much.
Thank you, Didier, for your leadership on that trial. And we'll have about 5 minutes of a little bit of a discussion, and I'll call everybody by their first names, so we stop with all the formalities. So, Joanna, what struck you about this SMART trial, and what tough question do you have for Didier?
Well, the toughest question I can think of is, you indeed focused on women, but still women with fairly classical aortic stenosis, high flow and high gradient. And what we see a lot in our practice is the low flow, low gradient aortic stenosis in women, exactly when the small annuli. Do you expect the same results in those patients? Because there were not too many of them in the SMART trial. Or do you expect even better results in those patients with self-expanding device?
So that's a very important comment, and I guess the mean LVEF was like close to 45%. The mean gradient was close to 45 millimeters of mercury at baseline. So indeed, we didn't have so many low flow, low gradient AS patients. But to your point, I do believe that potentially in this population, we could expect even greater magnitude difference between the balloon expandable valve and the self-expanding. Whether it's going to be more favorable for the patients in terms of clinical improvement, I guess, at least on the quality of life, we will have to wait for the 5 years follow-up to see if there is a real impact. But it's true that this is a subgroup that deserves a better exploration. Yeah.
What a great question. Vijay, you are been a champion of women in a very short period. Tell me, what does SMART mean to you? And when you have a woman with aortic stenosis, what are you going to do? Which valve, if they're going to have TAVR?
Yeah, absolutely. I mean, congratulations on recruiting nearly 90% of patients. And this study clearly demonstrates that, I mean, I used the phrase, one size does not fit all, and we need to be doing studies specifically addressing the differences in the anatomy and various pathophysiology in these patients. So I think even though the main primary endpoint was there was no significant difference, but women, quality of life matters so much, and this study you have shown nicely there's improvement in quality of life and several other important parameters. So I think this is something that we can, is individualized, tailored therapy, I think.
Thank you so much. And Didier, you're going to be presenting the large prospective. I think it's Hélène who's presenting. Isn't that right?
Going to present,
do you want to tell us
Rhea
about your trial so we could promote it and get everyone to?
Yeah, so stay tuned, guys. And London, in the London room by 6:20, I guess. Hélène is going to present Rhea, randomization of TAVI and surgery in a whole-comer, all-female population. So we're going to get even more information into the outcomes in this specific group of patients.
Perfect. And we're right on time. And now we go to Professor Julius Grapsa, who's going to tell us about underdiagnosing women with aortic stenosis. No one better than this fantastic imaging expert.
Thank you so much. I was about to say that my conflict of interest is that I'm a humble imager. So, and I'm in awe actually of Didier, Roxana, that delivered this amazing study. So, addressing the underdiagnosis in women with aortic stenosis, and as you know, the big challenge when we treat women with aortic stenosis is practically first when they are underrepresented in research. We didn't have a lot of significant percentage of women up to now that we see 90%. And then it's important that we don't have a specific criteria when it comes to gender. And, for example, what we know is the valve calcification is the only sex difference considered in the latest guidelines. And we don't have index values. We know that more women are most likely to have paradoxical low flow gradient. I'll explain to you why. And it seems that both workup time and procedural waiting time is longer for women. We'll discuss again why. And it seems that women, while they present with ambiguous symptoms, when they will present to the hospital, they will present in a more severe form than usual. Let's take you back to clinical practice, everybody, back to your hospitals. And we had an 82-year-old patient, female patient, with background of hypertension and diabetes. And I asked her, when did you first complain of your symptoms? She said, oh, that was more than 12 months ago. And I said, what exactly did you describe to your doctor? She said that I was breathless and I was not used to be like this. So I can see that I cannot do any more my usual, everyday work hours. And it seems that her general practitioner, as we have here in the UK, prescribed her iron deficiency anemia tablets. And so they actually she was diagnosed with iron deficiency and she was prescribed tablets and vitamins. And she was recommended to take it easy. The patient, though, she kept feeling worse. And she goes back to her GP, who actually suggests for her to have an echo and a BNP, and the echo was booked for 3 months down the line. But one day, she started having chest pain and visited the accident emergency department, and she had LVH on the ECG, troponin was negative, but they heard a murmur. So then, we practically kept her in. And the patient also, if you went back and you asked her, she said that she had a presyncopal episode. So she gets then admitted and we diagnose her with critical aortic stenosis and ejection fraction 20%. We say, why did that happen? The patient has been describing symptoms for more than 12 months. And why is that? Practically, women will present to you as having shortness of breath, dizziness, syncope, and they are way older than men. And actually will have more advanced heart failure symptoms. So they will keep having their symptoms, but they will underestimate them until they present to the doctor. And they will also have diabetes, hypertension, possibly chronic lung disease and atrial fibrillation. But also, we know that communication is key. How you are going to approach your patient, what are you going to ask them, how they are going to tell you that they are quite symptomatic. Many times you ask, an elderly patient, they say, no, I don't have any symptoms because I want to look after my husband who is at home and I'm their main carer. That's their only priority. Their priority is not to spend 5 days in the hospital actually looking for themselves. So practically communication is key because only 45% of women, they know that cardiovascular disease is their number one killer. And practically they're underestimating their symptoms. They say that they're less severe. And we start asking them questions. Do you feel breathless? How is your life now when compared to 5 years ago? So practically, we need to understand that aortic stenosis is very frequent among women. And you will see that there is no difference in prevalence of severe aortic stenosis in European population, also in the Australian ECHO database. So it's exactly the same prevalence in men and women. So why we see less frequently women is because, as we said, they underestimate their symptoms. And practically, they present with less aortic valve calcification when compared to men. But when they reach the hospital, they have more hypertrophied ventricle when compared to men, and they are more likely, therefore, to have paradoxical low flow log gradient. And we'll have an opportunity to discuss what that means for those that they are non-imagers. We love actually paradoxical in imaging. We call it a lot, and we will discuss it further. But as you can see, the delayed diagnosis and management can actually impact the survival. So this patient who arrived with ejection fraction 20% and critical aortic stenosis, now we cannot actually rescue the myocardium. Or if we rescue the myocardium, then the patient will need to be on heart failure medication. So how we can prevent this? How we can reach to diagnose women earlier and to treat them earlier? First of all, it's important to diagnose early aortic stenosis in women. Remember that they underestimate their symptoms. So practically, if you get the patient earlier and you diagnose aortic stenosis, then it's important to treat the patient as well. But you will see that women, they have a less likelihood to get an echo when compared with the same symptoms than a man. So here we are bringing the unconscious bias. Why, for example, you don't get an echo for your patient? Then, of course, we have the thresholds. We imagers, we love these thresholds. We love actually taking multi-window approach. And you will see that we have different thresholds on CT and echo for men and women. Something that we are waiting for the new guidelines to change. And there are, of course, different ways to assess a patient's eligibility for intervention, for surgery, whether they have paradoxical, whether they have low flow log gradient. We have a million ways now to assess a patient. For example, look at these two patients. So on the left hand is the patient 82 years old with severe low flow log gradient aortic stenosis, and practically she presents with ejection fraction 10-15%, and here CT does not show much of calcification. As we said, they will present with less calcification. However, heavy calcification on a 75-year-old male patient with severe low flow log gradient aortic stenosis. And of course, the 75-year-old male patient presented to the hospital earlier and got the treatment earlier. Another important element is that women do better with TAVI than SAVR actually. And this has been proved by several major randomized control trials. And it seems that if we diagnose aortic stenosis, we need to treat that promptly. So therefore, we know that women underestimate their symptoms, underdiagnosed, and then they have worse outcomes. So we need to be fully alert that also women, as we described, they have a smaller annuli, and this is important for pacemaker implantation, important, as we said, for the durability of the valve and outcomes post-actually intervention. So I will not repeat much of what Didier showed. The SMART trial was the first major RCT to recruit mainly women, 90%, and the results are very important and associated with what I showed you already, and we'll have the time to discuss. Within ESC, we are doing the valvular heart disease in women study that practically we want to test the social economic factors on why actually women are underdiagnosed and undertreated. So we are looking to see the time for diagnosis, time to presentation, and so on. So this will be hopefully bring us a step earlier to see what social economic factors affect women with aortic stenosis or with valvular heart disease in general. As take-home messages, actually, communication is key. We need literally to scrutinize the symptoms of our female patient. We need to understand why they perceive their symptoms differently and why they are coming with more advanced symptoms. Remember, it's not a man's disease. That knowledge is very, very old for us now. And it's important to understand that delays in referral and treatment has certain consequences in survival of women. And with that, I would like to thank you very much for your attention, and I'm really grateful to be with you. Thank you.
Okay, thank you very much, Julia, for that excellent presentation. I'm actually going to get started with Didier. Didier, in the cath lab, pardon the pun, we're very smart at treating our patients. Now we have the best valves to look after female patients, to make sure that we have good outcomes in areas that matters to them, such as quality of life. Julia's presentation is very stark. There are many women with aortic stenosis in the community are being told, you've got iron deficiency anemia, and they're not getting the right treatment. If they are not being diagnosed correctly, and if they aren't getting the right investigation, we're missing all these patients. They're not coming to us in the cath lab. What should we do about that?
I think it's something that we have all as the community to be aware of. We need to go and see our patients, to see the general cardiologists, the general practitioners, and to say, look guys, we are not doing the right thing. We have all these female who don't get the right diagnosis because they underestimate their symptoms. So I think we have to work on the identification and the early referral, because once they get in the cath lab, the outcome is not exactly the same as the one for the males, because they are at more advanced stage. So I guess we have something to do, and this is potentially the right setting, big cardiology meetings like that, to tell everybody that we need to do something for women.
Yeah, so it is a collective effort, raising awareness, education, because, ESC's mission is to reduce the global burden of cardiovascular disease. But if you're missing out these diseases in the community, then we're never going to achieve that. So, question for Joanna. So when doctors are treating patients, we as interventionists are treating these patients, should we be, I'm always very conscious when I'm with the female patient, I know that I have to take certain measures. So in the treatment of valvular heart disease, what are the strategies that you adopt to fine-tune your treatment to a female patient, for example?
I think that you see a lot of them with very hypertrophied ventricles, and of course in the cath lab one thing that you always worry about then is the suicide ventricle, especially when you are pacing for a long time. They really get into trouble hemodynamically, so you have to prepare for that, and you have to be aware of that. And act quickly. I mean, don't delay their treatments. Make sure that your referrings know to do the echo, to evaluate the echo, and to send the patient as soon as possible before they are decompensated, before they got syncope and broke both legs, etc. You hear those stories a lot.
So, and one final question to Julia. So, obviously imaging is the first point of contact. And other differences, we have seen that women get less echocardiography, and that has direct impact on their outcomes, worse outcomes. So what steps should be taken at the imaging level, and what advice or message that you have for us to improve on that?
That's a great question. Thank you, Vijay. And I will take the opportunity from Joanna, because she said the suicide ventricle. Sometimes they mention, it's a good overall LV, and then you go and see a very hypertrophied LV, and you really want to do a stress echo to show you the contractile reserve and to understand that this LV practically will dump the function. So it's important for us to do all diagnostic tools, like we start from a transthoracic, we have stress echo with contractile reserve, and people to interpret the stress echo. And then, of course, we can do CT scans. So it's important for us as imagers to map you the patient in order for you to go in and have the best outcome for the patient.
Yeah, absolutely. I mean, in the guidelines, we provide diagnostic algorithm. I think not just stopping with one imaging, but also make the on purpose. I'm going to investigate this patient further to assess what I need to do next is so important. So that's really brilliant presentation. Thank you so much, and I hope that we can move on from talking about this under treatment and specifically on the specifics of what we can do to improve the outcomes in our female population. So now it's my pleasure to invite my friend Joanna. I'm not going to say your second name either, Joanna, to discuss durability in TAVI valves, data, predictors, and the real-world insights. Thank you so much.
Thanks for having me. It's a great pleasure to be here. Durability in TAVI valves, data, predictors, and real-world insights. I mean, we treated the patient, but are we done? I think we need to monitor them carefully to make sure that they don't have recurrent heart failure symptoms and that they don't get into trouble again. So what is the bioprosthetic valve dysfunction? What are the causes? What are the types? I think in the SMART trial and the results you saw, Didier allude to it. And you should know that overall, the prevalence of this bioprosthetic valve dysfunction and the definition is that it's above 20 millimeters of mercury. So it's sort of mild dysfunction for most of the cases. What are the predictors? So female sex, of course, small annuli, other risk factors like hypertension, renal failure. Classically, we know that patients on dialysis will degenerate their valves really quickly. There's also prosthesis-related factors. So we talked about balloon expandable versus self-expanding valve. With balloon expandable valves and with surgery, we can have more severe PPM. Also, the impregnation of the valve leaflets with antimineralization treatment seems to be important. So you have both the non-structural valve dysfunction and you have structural valve dysfunction. The wear and tear on the valve, of course, can happen due to inflammation, due to turbulent flow. And you can have also valve thrombosis, some low level of valve endocarditis, and that can lead to structural valve deterioration. Also, moderate PVL, which will leave after the procedure, and also PPM, so not proper sizing, can lead to bioprosthetic dysfunction. It is a very small proportion of patients that will proceed to the stage 3 severe bioprosthetic valve failure. And that then leads to heart failure symptoms, reintervention, and even death. So these are the results for the midterm durability for patients with medium risk and also high risk. So you see that it's 5 years. It's fairly low for both surgical and TAVI devices. And we don't have that much data yet on very long-term follow-up. So we have the NOTION trial, which has 10-year follow-up, but of course the data is a little bit limited by the longevity of the patients. Those patients at enrollment were 80, and so of course there's a small number at risk at the end and competing risk. What is very encouraging is the data from both Partners 3 at 5-year follow-up, but also the low-risk Evolute trial. And you see that the low-risk Evolute trial actually shows better results for the self-expanding TAVI than for surgery. And then there's equivalent results in Partners 3. So in the SURTAVI and high-risk patients, you could see that the incidence of BVD in TAVI, self-expanding TAVI, was actually much lower than that in the surgical valves. Again, here we're talking about this more than 20 millimeter gradient hemodynamic cause of mild BVD. But nevertheless, even that results in long term more cardiovascular mortality, more hospitalizations for valve reintervention, worsening heart failure. And the effect, of course, we saw was much more significant in patients with annular diameter less than 23. So in the SMART trial, and I won't dwell too much on it because you just saw a beautiful presentation from Didier, no difference at 1 year in the clinical outcome, but large difference in BVD, again driven primarily by hemodynamic structural dysfunction and also non-structural dysfunction such as PPM. Thrombosis rates are very, very low, endocarditis rates are low, and also AV reintervention is very low, less than 1%. Predictors for the composite outcome are also different than predictors for BVD. So what predicts your outcome at long term is, or short term, is actually comorbidities, right? Heart failure, chronic lung disease, arrhythmia, most likely atrial fibrillation, and also probably this low flow, low gradient status as measured by SVI. So predictors for BVD, on the other hand, are actually the annulus area, the patient size, and also use of balloon expandable prosthesis. So if you are in your practice and you are following your patient post-TAVI and you have a rapidly increasing gradient, what does that make you think of? It makes you think of actually thrombosis on the leaflets. And if you perform in CTA, sometimes you will see subclinicals or not yet symptomatic leaflet thrombosis or so-called HALT. So in that case, what you can do is you can actually put them on anticoagulation. We know from Atlantis and from Galileo that in general, putting patients on anticoagulation without any other indication post-TAVI does not lead to better outcomes, sometimes even worse outcomes. But if you do have thrombosis on the leaflets, it may be useful to do that at least for a period of time to get rid of it and prevent further valvular dysfunction. And we are going to test this hypothesis also in the popular Atlantis trial, where patients with CT-proven leaflet thrombosis will get randomized actually to anticoagulation. And if they don't have it at 3 months, they will actually be left untreated. Even aspirin will be stopped. So if the patient comes back after 3 months and they still have evidence of heightened gradient, or if their gradients aggressively progressed over time, and they have symptoms, then your treatment option is to refer them back to the heart team to decide what to do further and if the valve-in-valve is an option. So these are our own data from an academic center in Groningen in the Netherlands, where we, over the last 15 years, performed 1,600 TAVIs. And out of those patients, 56 were bioprosthetic surgical valves, and only 6, so 0.37%, were actually TAVI degeneration. And you can see also that most of the devices that had valvular degeneration were direct flow, which is actually off the market and a very atypical valve. So we have only 2 cases of Edwards Sapien Medtronic Evolute that actually required TAVI and TAVI. So I thought, well, am I so lucky or am I so good at doing TAVI that I have so few reinterventions? So I asked Didier, who I know is very good. So in his 8,000 TAVI procedures over the last almost 20 years, he also has 25 cases of reintervention that required TAV and TAV, so 0.3%. And most of these patients were quite elderly. The median time to failure was 5 years, and most of the time it was stenosis. So when you have those problems, of course, first of all, the patient had a TAVI to begin with, so there were high surgical risk most likely. And they are somewhat, extreme cases where we don't have very many options if the patient is very symptomatic. So this was a patient that actually had such severe peripheral vascular disease and other comorbidities that they had initially a transapical Edwards Sapien, and now in October 2019 they had severe restenosis gradient with velocity about 4 meters per second, and severe symptoms, both angina and dyspnea. So here the coronary height was not a problem, and we actually felt quite comfortable, and we brought him back for the direct aortal TAVI with an Edwards Sapien, again with good result. This is, again, fairly atypical case, and I can say that has not been yet approved, CE marked for this indication. 84-year-old gentleman who had initially an Evolute valve placed and developed endocarditis later. And despite complete treatment of endocarditis, he kept having aortic regurgitation and getting admitted with decompensation. So we actually considered him also for evaluation for valve-in-valve, and we did this with Medtronic Evolute Pro. There's some tricks to do this, of course. It's a bigger frame, so you don't want to take the struts with you. And of course, you always have to think about coronary patency. And this is a case that I got from Didier, and this is really for experienced operators. Again, 80-year-old female with degenerated Edwards Sapien, fairly low coronaries. So what he had to do in order to prevent coronary occlusion, he had to actually perform basilica procedure, so laceration of the leaflets, which in itself is associated with fairly high risk of CVA. So you can see him using also the Sentinel cerebral protection device, performing the basilica and then nicely placing the evolute valve here. And before he releases the valve in the middle bottom picture, you see him injecting the coronaries to make sure that they're still patent. So very nice result despite complex anatomy, also horizontal aorta. So take-home messages. Bioprosthetic valve dysfunction is multifactorial, structural and non-structural. It is more common in SAVR and is associated with higher rates of adverse outcomes, with the caveat of competing risk of mortality. It is more common in small annuli in patients treated with balloon expandable valves and in patients with low SVI, so low flow, low gradient. Severe SVD requiring re-intervention after TAVI. It's not yet common in Europe. It's 0.3%, as you can see, in 2 centers, but may become more prevalent as we treat younger, low-risk patient population. Thank you.
We just have a couple of minutes so that we could be right on time. So I'll start with you, Didier. Valve durability, very important question now, especially as we go to the younger patient population, and probably it's not a fair thing to look at those very high-risk patients and say you only had 25 of them come back. You think that, what is that number? That number of the need for a re-intervention. But think about it in a small annulus. That even has to be a different situation.
So that's a very important question, Roxana. I think we have to put everything in perspective with the own life expectancy of the patient. If you take a 70-year-old gentleman or a lady, it's about 12 years of life expectancy. So you have to put this in perspective with the number of procedures that you're going to require. So I would say that for a patient with the longer life expectancy, I would use the device according to his anatomy that is going to provide the expected longer durability. Then you have to integrate the coronary access and things like that. But I think that durability, once we get the 10 years follow-up of both major low-risk trials, we're going to have more insights, and we have to match it with the anatomy, but as well as the life expectancy of the patient.
Very good. Julia, this HALT situation is an imaging finding. It's never panned out on a clinical sense, but it does seem that there is anticoagulation and it goes away. You think that this is going to have an important impact on durability of the valve, that maybe we were too fast to peel off the anticoagulation on some of these patients, especially the young ones, or is this just an imaging finding?
No, it's a great question because it makes us think about durability, anticoagulation, and now, for example, we have a new protocol in my hospital to do a CT HALT, and then it gives us more information, and then we are guided on the anticoagulation, of course, with risk factors. So I think you're right that it may change our practice the way we're thinking.
Great, thank you, Julia. If I can have this slide up on the screen, please. So, first of all, I think it starts with diagnosing correctly. It's the entire pathway of the patients, and we're not, based on Julia's presentation, we're not quite there in terms of diagnosing, and we need to continue with raising awareness and education of individuals that are dealing with these patients at the front door, really. And then when they come to have the investigation, which in a sense is the imaging investigations, to make sure that we pick these conditions up and follow the diagnostic algorithm in order to make sure we have a step-by-step approach to fine-tuning towards the treatment. And of course, when these patients come to the cath lab, then we have incredible progress, and SMART trial is one of the very impressive study, pretty much exclusively recruiting female patients, and demonstrated some important advantages of using them. So I think we're making headway. Professor Mehran led the Lancet Commission to reduce the global burden of heart disease in women by 2030. Step by step, slowly, I think we're getting there. So with that, I'd like to take the opportunity to thank my chair, Professor Mehran, for outstanding chairing of the session together. Pleasure to chair this with you. And also for the absolutely brilliant presentation from the three of you, Didier, Julia, and Joanna. And thank you all for joining us this afternoon. And we'd love to hear your feedback. So you can scan the QR code right there and provide your feedbacks on our session. Thank you very much, everyone.